All right, guys, we're gonna be doing chapter 15, psychological disorders. Let's just hop right into it. So, on chapter 1, we have psychopathology, which is the study of psychological disorders, including their etiology, which is causes and the treatments. So we have psychological disorder, which a psychological disorder is pretty much characterized by abnormal thoughts, feelings, or behaviors, thoughts, or inner experiences that are atypical, dysfunctional, dangerous, and their signs are psychological disorders. However, there's no single definition to a psychological abnormality or normality. Just because someone is atypical does not mean that they have a disorder, which, as you see described in the pictures below, people with red hair are not labeled as abnormal. A redhead is not abnormal. But pretty much, psychological disorders, pretty much, the way I learned is they're atypical things that can affect your daily life in negative aspects. So they can affect your daily life, but not in a positive aspect, only in a negative aspect. They can hinder maybe your sociality or something of that nature. Um, so definition of psychological disorders. So psychological disorders are cultural expectations. So obviously, a psychological disorder can be deemed as maybe godlike, maybe ethereal, maybe blessed by God in a way, or blessed by some superstitial being, or something of the sort. While in another culture, it can be signified or it can be identified as something as like a disability or some disorder or something like that. So violating cultural expectations is not enough by itself to identify a psychological disorder. Social norms vary between cultures. What is considered to be appropriate in one culture may be viewed as differently in another. Hallucinations is a violation of cultural expectation in Western societies. People report hallucinations are likely labeled as psychological disorders. However, in some cultures, certain types of hallucinations are highly valued. Um, Harmful dysfunction. Wakefield proposed a more influential concept, which he defines as psychological disorders as harmful dysfunction. Dysfunction occurs when an internal mechanism of cognition, perception, learning breaks down and cannot perform in its normal function. So, harmful dysfunction. Wakefield pretty much just exemplified a disorder as something that really just affects the psyche and hinders the psyche. For a dysfunction to be classed as a disorder, it may also be harmful, leads to negative consequences for individuals or for others as judged by standards of individuals' culture. So next we have the APA, which is the American Psychological Association. So, a psychological disorder is a condition that consists of the following significant disturbances in thoughts, feelings, and behavior outside of cultural norms. The disturbances reflect some kind of biological or psychological or development dysfunction. The disturbances lead to a significant distress or disability in one's life. Example, difficulty performing appropriate or expected roles. Despite in many existing definitions, there's no universal agreement on the boundary between disorders and not disorder. So we can't objectively say that we know what a disorder is, but we think of a disorder as something that affects cognition, that acts as a hindrance towards daily activities, and pretty much just something that can act as something that just pretty much occludes a lot of the normal biological and psychological functions that we experience. So next, we're going to go to the DSM, which is the Diagnostic and Statistic Manual. Diagnosis is appropriate for identifying and labeling a set of defined symptoms. It requires classification systems that organize psychological disorders systematically. This was published by the American Psychiatric Association. It was first published in 1952 and has undergone numerous revisions. The first two editions listed homosexuality as a disorder, but was removed in 1973. So from that, we can infer that pretty much the DSM is most likely going to be rectified a lot, and we're going to rectify this to become more leaning or just more turning to the other side of the positive spectrum and having a better objective definition of what psychological disorders are, the diagnostics for the psychological disorders, and the statistics for the psychological disorders, and a lot of the ubiquitous nature of some of these disorders. So, categorize and describe each disorder. Diagnostic features, overview of the disorder, diagnostic criteria, specific symptoms required for the diagnosis, and prevalence. So, we have diagnostic criteria. So, DDPR is how you can remember how to categorize disorders. So, or DFDC PR if you want to, but I'm probably going to remember this as DDPR: diagnostic features, diagnostic criteria, prevalence, and risk factors. So it provides information about comorbidity, which we will go more into comorbidity in other slides. But for now, just pretty much just think of comorbidity as a dual diagnostic sheet, which was actually what it was named, from what I've heard. But now it's actually deemed as comorbidity, which is just obviously having two disorders in one, or the prevalence of having the two disorders in one, and the percentage rate. So the prevalence rates. This graph shows a breakdown of psychological disorders comparing the percentage prevalence among adult males and adult females in the United States. The DSM-IV has since been supplanted by the DSM-5. Most categories remain the same. However, alcohol abuse now falls under the broad alcohol use disorder category. So as you can see in this diagram, or in this bar graph, the DSM disorders are highly feminine. A lot of the disorders and a lot of the social and anxious disorders are mostly common in females, while a lot of the more violent, abusive disorders are commonly seen in males. A lot of the aggression and hostility you'll see in males, like antisocial. You'll see substance abuse and a lot of things that wrap around that. Narcissism, commonly in males. While you see things like major depressive disorder and common in females, specific phobia common in females, post-traumatic stress disorder common in females, generalized anxiety disorder common in females, panic disorder common in females, OCD common in females, and dysthymia common in females, which dysthymia is pretty much just persistent depression. Comorbidity, obsessive compulsion disorder, major depressive disorder. Obsessive compulsion disorder and major depressive disorder frequently occur in the same person, which I said comorbidity is pretty much just a percentage of two disorders that intertwine and interpolate into one. So as you see, major depressive disorder and OCD are highly common. That's a high percent rate. 41% is pretty common. The International Classification of Disease, which is the ICD, classification criteria used for specific disorders are similar to the DSM, but there's some differences that exist. But mainly, I would think of ICD as more clinical, more of the clinical corroboration, rather than more of the therapeutic therapeutic corroboration. I see ICD as something more of clinical diagnosis rather than DSM, which is more of a statistic manual and more of a criteria to follow, so you can label someone as schizophrenia, or as schizophrenic, or as hyperthymic or something like that. So use to examine the general health of populations and monitor prevalence of disease health problems internationally. Worldwide, the ICD is more frequently used in clinical diagnosis, whereas the DSM is more valued for research. DSM includes more explicit disorder criteria as well as extensive explanatory text. DSM is a classification system used among U.S. mental health professors. So, another thing that a lot of people went through back in more the 15th to 14th century, as you know, there's a lot of prevalence with religious and a lot of religious ideology back then. A lot of things that were deemed as like sanctity in a way, and there's just a lot of these sacred things, and a lot of people just deemed some of these things that people would experience as demons inside of their head. So obviously this probably wasn't the most ethical, and obviously this probably wasn't the most righteous or right at all, period, thing to do. But so basically what this is this was a practice called the extraction of stone madness. It was a 15th century painting of the Hieronymus Bosch. A practitioner is using a tool to extract an object supposed of stone madness from the head of an afflicted person. So you can see that this afflicted person is going to die, especially with 15th to 14th century medicine. They're not going to survive. If you penetrate a hole through a person's skull, this afflicted person will die. So basically, they thought of this thing which was called trepanation. Trepanation, they seen supernatural perspectives as this thing called trepanation, which we know that trepanation is pretty much just carving a hole in the skull. And they thought that this was going to elicit demons outside of their head, that demons were going to disperse and come outside their head, and they would be free from the disorder symptoms that they had. That was pretty much the supernatural perspective of psychological disorders. So, and the practitioners were of black magic sorcery, and they just thought that these afflicted people were just possessed by spirits or something. So dancing mania, which is an epidemic in the Western Europe from the 11th to 17th centuries, it was a group in which people suddenly began dancing with wild abandon. Some would dance for weeks or days, screaming of terrible visions, although the cause is unknown. The behavior is attributed to many supernatural forces. I don't know anything about the dancing mania. There's probably more research on this. This is a really interesting topic, though, that I definitely should step into. I'll probably look more on that, and we'll see. I'll see about that. So, the biological perspective views psychological disorders as linked to biological phenomena, genetic factors, chemical imbalances, and brain abnormalities. So, and also, a lot of the biological factors can be routed from this thing called diathesis, which we'll get into later. But for now, let's just focus on this. Supported by evidence that most psychological disorders have genetic components, a person's risk of developing schizophrenia increases if a relative has schizophrenia. The closer the genetic relationship, the higher the risk. So we see on this board that first cousins have a 12.5% chance, or around this area, while uncles, aunts, nephews, and nieces, grandchildren, and half siblings have around 25% shared genes, so they have 25% of getting a disorder. Parents, siblings, children, and fraternal twins have around 50% genes shared, which can give them obviously higher rates of schizophrenia. And if you have a identical twin, he's gonna have 100% the same genes shared with you. So if they have schizophrenia, you're gonna get schizophrenia. So psychosocial perspective emphasizes the importance of learning, stress, faulty, and self-defeating thinking patterns and environmental factors. So like I was saying earlier, the diathesis stress model views causes of psychological disorders and combinations of biological and psychosocial factors. So pretty much diathesis is pretty much just taking socio-environmental factors and also taking biological factors, putting them into one word, and adding stress, which is going to give you the probability of developing this disorder. So people with an underlying predisposition of disorders, diathesis, are more likely than others to develop a disorder when faced with adverse environmental or psychological events. A diathesis can be biological or psychological vulnerability. So fear versus anxiety. What is fear? Fear is more of an instantaneous emotion that's elicited when you see something that you deem as a threat. So fear is going to be more of something that's imminent, something that's going to happen right there, snap. You're gonna feel fear, and it's going to be because of something you deem as a threat, which it'll calm down. Fear is a transient emotion. You see something, you get fearful, you get plugged into that sympathetic nervous state, and it rises down and reduces down over time. But anxiety can be apprehension, it can be avoidance, it can be cautiousness. And why do we have anxiety? We can avoid something, circumvent something, and have cautiousness from something because we're going to see it as threatening, or we're going to see it as something that's a potential danger to our environment or to our well-being or to our physiological needs. So obviously anxiety can cause stress and induce stress, which we learned in the last chapter what stress does to the human body. But Yeah, this obviously isn't good, but chronic stress can obviously induce high stress on the body, chronic stress on the body, which obviously we know it's gonna lead to immunosuppression and autoimmune diseases. So it motivates us to take actions and avoid things. So the level of duration anxiety usually matches the magnitude and the potential threat. However, some people experience anxiety that is excessive, persistent, and out of proportion to the actual threat. Anxiety disorder is characterized by excessive and persistent fear of anxiety and related to disturbances behavior. So, its prevalence is about 25 to 30% of the U.S. population during the lifetime. It's more common in women than men, and most frequently occurring in mental disorders. So, let's get into phobia. So, phobia involves excessive distressing and persistent fear or anxiety about a specific object. So, a phobia, let me get this right. So, let me tell y'all. Wait, but after, hold on. People may realize their fear and anxiety is irrational, but they may still go to great lengths to avoid the stimulus. And prevalence can be 12.5% of the U.S. population at some point of their lifetime. Common and specific phobias include. But before I read off the specific phobias, I want to say, let's demarcate phobias and fears. So when you're fearful of something, you're gonna avoid it. If you see it, you're gonna scream. You're gonna be like, oh my god, jeez, man, don't scare me like that. But then you're gonna start to acclimate to that thing. Phobias is more of a histrionic or more of an excessive reaction towards something. So if I was to see a spider on my screen, I would jump, run, and scream. Whereas if I was fearful of the spider, I jump back and be like, "Oh my god, it's a spider." That's a phobia, and that's how you demarcate phobias from fears. So acrophobia is heights. We know aerophobia is flying. We know arachnophobia is fear of spiders, and we know claustrophobia is a fear of being in a tight or more of an isolated space. So when these people are caught in a lot of these a lot of these events that they have phobias from, it can induce panic attacks and excessive emotion and excessive reactions. So I'm sorry, I was drinking tea. So yeah, we know we know a lot of these phobias are just more excessive than just a fear. And if you were caught in the situation, you most likely know that you had a phobia. So agoraphobia, which is more of a social anxiety, more of a social anxiety phobia, which you just don't like socializing. That's agoraphobia. It's listed by an intense fear of anxiety and avoidance of a situation that might be difficult to escape and receive help from if one's experiences a panic attack. These situations include public transport crowds and being outside and home alone. So, wait, is that not claustrophobia? Hold on, guys. I might have just informed y'all about the wrong information. Wait, let me look this up real quick. Hold on. If I was Oh, okay, I see. Yeah, I was wrong. I'm so sorry, guys. So agoraphobia. See, humans always make mistakes. I'm sorry. But agoraphobia. Oh, and by the way, guys, I'm learning as you learn too. We're both learning this. I have to take my exam as well. Um, so agoraphobia is literally right here. It's characterized by avoidance in a situation which it may be difficulty to escape and receive help, which induce panic attacks. So agoraphobia is basically when you're in a tight space, maybe a train station or a crowded, like someplace crowded like New York City, and you just are overwhelmed and you can't find any sort of escape, and you're surrounded by all these people, which induces panic attacks. Um, so acquisition of phobias through learning. This can be learned through classical conditioning. A child is bitten and becomes associated with the biting. A child experiences fear around dogs. So we know what classical conditioning is. Mm. But every time classic conditioning comes, I'd like to review it just in case, because classical conditioning is a really important topic. Mm. One of the more important topics I feel like you should definitely take from psychology. So classical conditioning is pretty much taking a neutral stimulus and um, um, a neutral response, and you're pretty much creating a conditioned stimulus, a conditioned stimulus and a conditioned response. So after the person that you're doing this on acclimates to the condition, response and sort of interconnects and associates the condition response and or the condition response. They get that condition stimulus. So when, like in the example, when the baby got bit by the dog, they associated the dog with canines and biting, which they it elicited a neutral stimulus, which is the fear of dogs, which can be dog phobia. I don't know. Probably not dog phobia. Scientists probably use more of the phylum scientific words and scientific jargon for dogs, but it's probably not dog phobia, but I don't know, something of the sort. Conditioned fears develop more readily to fear irrelevant stimuli, images, or snakes, spiders that fear an irrelevant stimulus. So vicarious learning can also be, we know what vicarious learning is. We covered that in our learning chapter, actually. I think our learning and memory chapter. Yeah, where we just see something on TV and we learn, and it becomes a classical conditioned thing in our mind, pretty much. So we see what happened to somebody, or no, it's operant conditioning, my bad. So we see what happened to somebody. We see that they did this and it reinforced the behavior, and they got a reward for it. So, or this thing acts as a reinforcement for something, and then they keep doing it. So we seen that we seen that in vicarious shows, like, oh, if you talk to somebody from a gang, it's gonna create it's gonna create danger, which we obviously know danger can lead to some threatening, or is something threatening, like the taking of a life. So if you threaten a gang, let's say hypothetically, you threaten a gang, we see you threatened a gang on TV, we see the gang has this reaction, and we see that the gang beats you up, which is some sort of negative punitive measure after threatening the gang. And we could learn that by our vicarious learning. Verbal transmission of information, that's just saying something like, oh, I'm scared of spiders. We're scared of spiders. We're scared of spiders. Spiders are scary. Spiders are scary. And a child, or even you, can learn to have this sort of fear from spiders or anything, because it's prevalently said and thought about within your environment. So social anxiety disorders, characterized by extreme persistent fear and anxiety in avoiding social situations. We pretty much know anxiety disorders, so I think I'm going to skip that. It's associated with lower education attainment, lower earnings, poor work performance, and unemployment. Safety behaviors, mental or behavioral acts that reduce anxiety in social situations by reducing the chance of negative social outcomes. Avoiding eye contact, rehearsing sentences before speaking. The prevalence is 12% of Americans during their lifetime. Comorbidity, the comorbidity is highly associated with alcohol use disorders. Individuals may self-medicate to reduce anxiety in social situations, which obviously means taking drugs in social situations or recreational substances in social situations to reduce anxiety. Fear of social situations possibly developed through conditioning. 92% samples of adults with social anxiety disorders report a history of severe teasing in their childhood. Behavioral inhibition is when when you're presented with a stranger, that you can have this induced stress. So when you see some random stranger that you don't know, it induces some sort of anxiousness or stress within your body. Okay, so panic disorder. Panic disorder is reoccurring unexpected panic attacks along with at least 1 month of persistent concern about the additional panic attack. Worry over the consequences of the attack, of self-defeating changes in behavior are related to the attack. Comorbidity, anxiety disorders, and major depressive disorder. Panic attack is a period of extreme fear, discomfort that develops abruptly and reaches a peak within 10 minutes. It can be expected in a response to an external trigger or an unexpected panic attack. Some physical manifestations of panic attacks are shown. People may also experience sweating, trembling, fear, faintfulness, or fear of controlling, among other symptoms. So basically, panic attacks can be induced by some sort of external sensory. And actually, we'll cover more panic attacks. They get so, like, it's like hypochondriasis, which they're just so fearful of the panic attack occurring that it stresses them out, and hypocritically or paradoxically, they end up having a panic attack. Like if you like for hypochondriasis, if you don't know what hypochondriasis is, it's pretty much the fear of getting an illness if you're hyper stressed about if you're hyper stressed about not acclimating about obtaining or procuring this disease or disorder, then end up you could end up procuring the disorder because you're so stressed and you're getting the immune suppression and the autoimmune disease, so you end up contracting the disease. Like it's pretty funny. Well, it's not funny, but it's pretty paradoxical. Let's just say that. So 43% of heritability, the locus coeruleus, and the brainstem is possibly involved in major sources of norepinephrine, which is a neurotransmitter that triggers fight or flight responses. Activation is associated with anxiety, fear, produces panic, and like symptoms in non-human primates. Conditioning theories, panic attacks are classical conditioning responses to subtle bodily sensations resembling normal occurring when one is anxious or frightened. Cognitive theories, individuals with panic disorder are prone to interpret ordinary bodily sensations catastrophically, setting a state for panic attacks. So, like I said earlier, an individual with panic attacks is prone to getting a panic attack because he's hyper fixated on even small subtle sensory imbalances. So he's so fearful of even contracting the panic that he ends up getting the panic disorder because he's so worried about the subtle sensory imbalances that are inflicted on him or that he feels. Like it's so paradoxical. But also I'd like to go more into the locus coeruleus, because I do want to be a neuroscientist. And obviously, you got to know about the locus coeruleus. Locus coeruleus is an area in the pons that actually is it's like this long string of ganglia, which create norepinephrine, and we know that norepinephrine is pretty much associated with stress hormones, and during sleep, if this locus coeruleus is most likely going to be inhibited, and if you're hyper stressed, then your locus coeruleus is not going to be inhibited, and your locus coeruleus is going to be all over the place, and it's going to be active, which is going to inhibit you from sleeping. Because if you're stressed, the locus coeruleus and norepinephrine pretty much inhibits those spots in your brain that allow you to sleep, or that allow sleep to precipitate. So, generalized anxiety disorders, a relative continuous state of excessive, uncontrollable, and pointless worry and apprehension. Diagnosed criteria: the diffuse of worrying about apprehension is not a part of another disorder. Symptoms occur more on days, not for 6 months. Symptoms are accompanied by any 3 of the following symptoms: restlessness, difficulty concentrating, being easily fatigued, muscle tension, irritability, and sleep difficulties. This affects about 5.7% of the U.S. population during their lifetime. Females are 2 times as likely as males to experience the disorder, and the comorbid with mood disorders and other anxiety disorders. So, let's look at the cognitive theories about generalized anxiety disorder. So, cognitive theories are worrying that represents a mental state of avoiding more powerful negative emotions, perhaps stemming from earlier unpleasant and traumatic events. Worrying acts as a distraction and from remembering painful childhood experiences. Longitudinal studies found that childhood mistreatment was strongly related to the development of a disorder during childhood. So pretty much, this cognitive theory states that worrying actually acts as a distraction from a lot of the negative or neurotic emotions that we experience. So OCD, pretty much in the name, obsessions and compulsions. It's involved in thoughts and urges that are intrusive and unwanted. Obsession and or need to engage in repetitive behaviors or mental acts, compulsions. So obsessions is persistent and unintentional and unwanted thoughts and urges that are highly intrusive and unpleasant and distressing. Common obsessions can be concerns about germs, contaminated doubts, order of symmetry, and aggression for lustful urges. So obviously you're going to obsess over something. You're going to obsess over something being clean. You're going to obsess over the door not being locked. You're going to obsess over maybe your fan not being on. Maybe you're obsessing about your dog potentially running out. The obsession is pretty broad. It gets crazy with OCD. People can obsess about the smallest things. I heard that someone with OCD, actually, if they couldn't step If they took a step, they felt they needed to take a step back. Which obviously, if you do that, you cannot move. So it was pretty yeah. It gets pretty bad with OCD sometimes. That's a severe case. A compulsion is a repetitive ritualistic behavior. So basically, a compulsion is going to be something that we're going to do constantly and constantly, and it's going to act as this sort of it's going to act as this sort of classically conditioned thing. So we're going to get this stimulus, and as a stimulus, we're going to feel that, oh, this needs to be clean. It's still dirty. My hands are still dirty. I have germs on my hands. And our condition response, or our condition reaction, is going to be washing our hands repeatedly until our hands start bleeding, to reduce the stress and to reduce that stimulus that we're constantly getting. That is a compulsion. Prevalence is experienced by 2.3% of the U.S. population in their lifetime. Oh, the person usually knows these obsessions and compulsions are irrational, but suppressing them is extremely difficult. So like I said earlier, repetitive hand washing, checking if the door is locked are common compulsions among the obsession compulsive disorder. Other common compulsions include cleaning, ordering, and counting. Body dysmorphic disorder. So it involves preoccupation and preconceived flaws in the individual's physical appearance, causes a person to think they're unattractive or deformed. Typically involves skin, face, hair, and focuses on the bodily areas, causes a person to engage in repetitive ritualistic behaviors and mental acts, constantly looking in the mirror, trying to hide offending body parts, comparison with others, and cosmetic surgery. So one of the biggest things, we know cosmetic surgery, sometimes it can be involved with insecurities and some sort of body dysmorphic disorder. And we know that obviously if you compare yourself to others, you're most likely going to be comparing yourself to people who are deemed as some sort of idol, something more to aspire to, or more of the notions of the contemporary people that perceive that this body is perfect, the perfect body. They're going to be comparing themselves with the perfect body, which obviously in society now, the perfect body is pretty theatrical, pretty dramatic. Like you're not going to be, it's not going to be naturally born to have certain features that these people want and that these people end up getting. And that's what causes a lot of women mostly to get the cosmetic surgery and to have these body dysmorphic disorders, because they're comparing themselves to others. So, but basically body dysmorphic disorders doesn't mean that it's the whole entire body. Body dysmorphic disorders can be small, meticulous, minute things about your body, like even just maybe as minute as the way your thumbnail looks. Like it can get that bad. So it causes someone to cover their thumbnail. Maybe they'll cover their hair. Maybe they'll cover their face or their ears. Maybe they cover their whole head because they think their head is too big. That can be some sort of example of body dysmorphic disorder. Okay, so next we're going to hoarding disorder, which hoarding disorder is pretty much keeping things that are insignificant, trivial, and just keeping some frivolous objects. Like, pretty much like, say if I was to keep not a shoebox, but say if I was to keep earphones that are broken because you think that it can have some future use. Which, I mean, if you do physics or if you do chemistry, maybe you could put those earphones to use. Or maybe if you're an electric engineer, or maybe if you are an engineer, maybe you could put it to use. Maybe you could use functional fixedness to put it to use. You never know. Maybe these hoarding disorder people have some sort of crazy functional fixedness and some sort of crazy abstract thought. But this is pretty much the hoarding disorder. So so they have excessive cluttering to diagnose hoarding disorder symptoms of another disorder. I feel like I did have this hoarding disorder when I was a child, because I did not want to. It was pretty hard for me to let go of a lot of things. So maybe I did have the hoarding disorder at one point. Genetics, 5 times more frequent in the first degree relatives of people with OCD. Identical twins, 57% concordance rate. Fraternal twins, 22% concordance rate. Genes involved regulate functions serotonin, dopamine, and glutamate. Symptoms of OCD are learned responses resulting from both classical and operant conditioning. One, a neutral stimulus plus an unconditioned stimulus. Like I said earlier, anxiety or distress. Once an association has been acquired, encounters of the NSF or of the NS triggers the neutral stimulus, anxiety, and obsessive thoughts. Anxiety and obsessive thoughts continue until the strategy is identified to relieve it, which causes the classical conditioned response. Relief may be ritualistic behaviors of mental activity, reduces anxiety, compulsion acts, becomes negative reinforcing. Yes, let's get into the brain, the orbital frontal cortex. So OCD circuit, several interconnected regions influence the perceived emotion value of stimulus and selective behavior in a cognitive response. Abnormalities in these areas may produce symptoms of OCD. Anterior cingulate cortex can be involved in hoarding disorder, which the anterior cingulate cortex is mainly involved in a lot of emotion and personality, but I do need to get more of some sort of more meticulous definition for how the anterior cingulate cortex would be involved in hoarding disorder, which I will find out. Prefrontal cortex is involved in body dysmorphic disorder, which obviously you're going to be having. The frontal cortex is one of the primary places you're going to have a lot of the judgment. It's going to judge how you assess situations and judge the dangerous situations. So if you assess yourself, if you think that somebody's going to judge you, obviously you're going to have some sort of your prefrontal cortex neurons are going to be lighting up when having this sort of body dysmorphic disorder. Orbital frontal cortex, obsessive compulsion disorder. Honestly, I honestly cannot tell you a lot about the orbital frontal cortex, but it becomes hyperactive in people with OCD, provoking them to do such tasks as looking at photos of a toilet and pictures hanging crookedly on the wall. The orbital frontal cortex is also involved in a lot of decision making. So this is why a lot of the neurons in the orbital frontal cortex light up when thinking or when looking at a lot of these these things that are deemed or that a lot of these people with OCD deem as messy or not fit, and it hyper activates that orbital frontal cortex because they want to make that painting straight and perfect. Perfectionism. Definition of PTSD: individuals was exposed to the witness or experience the details of traumatic experiences, actual threatened death, serious injury, or sexual violence. APA PTSD was first recognized in soldiers who engage in combat. Symptoms occur for at least 1 month. Like I said in the last chapter, I'm pretty sure. PTSD was actually not named PTSD in World War II. It was just named something like no. In World War One, it was named shell shock, and then in World War II, it was named something different. I'm pretty sure. But symptoms are intrusive, distressing memories of the event, flashbacks, avoidance of stimulus, persistently negative emotional states, feelings of detachment from others, irritability, proneness towards outbursts, and exaggerated startle responses. So risk factors of PTSD: traumatic experience. Those involved in the harm carry greater risk than those who do not. Lack of immediate social support. Social support or comfort, advice, and assistance from relatives, friends, and neighbors can reduce the risk of developing PTSD. Subsequent life stress, female gender, low socioeconomic status, low intelligence, personal history of mental disorders, history of childhood adversity, family history and mental disorders, personality characteristics, neuroticism, somatization, which is a tendency to experience physical symptoms when encountered stress, possessions of one or two short versions of the gene that regulate serotonin. Yeah, and obviously if we don't have a lot of serotonin, we're not going to be indulging in a lot of happy or excited moods. That's why we have SSRIs for a lot of people who are depressed and don't have a lot of emotional excitation as a lot of normal people. They're more apathetic, or they're just more sad and depressive. Condition theories: traumatic events, UCS; extreme fear of anxiety, UCR; Cognitive, emotional, physiological, environmental clues associated with a traumatic event become a conditioned stimulus. So, yeah, a lot of these are conditioned stimulus, like they said, PTSD, any sort of any conditioned stimulus can any conditioned stimulus can be any external factor or any sort of factor that re-immerses you inside of the moment that you were in, that you obtained that PTSD, or yeah, that PTSD, like that traumatic event that you experience, any type of sensory or external sensory that you feel brings you back in that moment, causes hyper anxiousness and hyper fear of doing it, which is gonna cause someone to be hyper anxious, hyper fearful, hyper irritable, and extremely vigilant. So, cognitive theories, two key process in the development of maintenance PTSD, disturbance in memory for an event. Poorly encoded memories, trauma can become fragmented, disordered, and lack detail. Individuals cannot remember an event in a way that gives meaning and context, and may become haunted by these fragments. Involuntary triggers by stimulus associated with the event, negative appraisals, the trauma, and its aftermath, e.g., I deserve to be raped because I am stupid. I really hope my thing doesn't get banned, but yes, people can have these negative appraisals. When I first saw this for the first time, I was like, wow, that is insane that actually is said by someone. That's very, very bad. But this may lead to dysfunctional behavior, patterns that maintain symptoms and prevent changes of problematic appraisals. So, also with this theory, the disturbance theory, and pretty much encodes that there's more of a granular structure, and that a lot of these memories are fragmented. So, the memory that was the most emphasized can trigger an event in a way, because a lot of, well, and then also you got to remember, a lot of this stress, actually something I didn't know, a lot of stress causes the hippocampus to shrink, hippocampic atrophy, pretty much. Which can most likely lead to the fragmented memories of a lot of these PTSD patients. So that's one theory, though. That's just one theory. But characterized by massive disruptions in mood and emotion that can cause distorted outlooks on life and impair ability to function. Depressive disorder. Depression is an insistent, persistent sadness, and is the main feature. Bipolar related disorders, which is mania, maniac episodes, a distinct period of abnormality, persistent elevation, expansive or irritable mood, abnormally persists, increased activity lasting at least 1 week. So major depressive disorder, the diagnosed criteria, depressed mood most of the day, nearly every day. So they have a loss in interest and pleasure in usual activities. There's at least 5 symptoms for at least 1 to a 2 week period. Symptoms cause significant distress or impair normal functioning, and they are not caused by substances or medical conditioning. Major depressive disorders and episodic symptoms are usually present at full magnitude for a certain period of time, and they gradually diminish. So some symptoms of major depressive disorder can be weight loss, weight gain, decreased appetite, difficulty failing or falling asleep, to too much sleep, which I told you guys what happens if you're stressed. You cannot fall asleep. Psychomotor agitation, psychomotor retardation, which is most likely a lot of those neurological motor or kinesiological movements from the brain is most likely going to be impaired, and psychomotor retardation, which is going to lead to maybe reduced movement or a lot of these reduced excitations in the in a lot of the motor cortex or the motor cortices. But just in case I'm wrong, let me look it up because I didn't look this up. Hold on. So it says that, yeah, okay, so psychomotor retardation involves the reduction of movement, and psychomotor agitation involves various disorders and health conditions that is characterized by unintentional, purposeless motions and restlessness, often but not always accompanied by emotional distress, and always indicative for admission. So pretty much what this is saying is that a lot of these, the psychomotor agitation is a lot of just these random movements that are not a lot of these random restless involuntary movements. So it's just pretty much just moving slightly because why not? Really weird, honestly. Yeah. But so fatigue slash loss of energy, feelings of worthlessness or guilt, difficulty concentrating, indecisiveness, suicidal ideation, which is just thoughts of suicide. Prevalence affects about 6.6% of the population each year and 16.9% of the U.S. population in a lifetime. More common among women than men, comorbidity with anxiety disorders and substance abuse disorders. Unemployment, low income, living in urban areas, and being separated and divorced or widowed. And those are the risk factors, by the way. So, subtypes of suppression, which is seasonal patterns, peripartum, and persistent depressive disorder, which is dysthymia. So, seasonal pattern is pretty much depression from a lot of seasonal changes or a lot of the environment and the weather factors. So, you'll experience some of these depressive disorders and some of these depressive symptoms during certain parts of the year. Like maybe if it's fall, maybe if it's winter, it's winter, it's cold, depressing. You're pretty much, you feel like it's cold, vacant, and you feel like there's no air molecules that are hugging you, and you don't feel warm. You feel cold. If it's cold and raining, you're most likely going to be in a blue, depressed mood. So, peripartum, which is the onset of postpartum depression, which is major depression during pregnancy or the 4 weeks of the following birth, which basically postpartum is just depression occurring in a certain trimester of the conception period. Persistent depressive disorder, which is dysthymia, which is pretty much a chronic depressive disorder that persists for at least 2 years. This has to persist for at least 2 years to be labeled as a depressive disorder. And there's also another depressive disorder that we're going to probably get into called major depressive disorder in the next slide, actually. Maybe. No, we're not. So bipolar mania, which involves mood states that fluctuate between depression and mania. So symptoms of mania is excessively talkative, excessively irritable, exhibits flight ideas, talks loudly, rapidly, abruptly, switching onto other topics, easily distracted, exhibits grandiosity, inflated, unjust self-esteem or self-confidence, showing little need for sleep, taking on several tasks at once, and engaging in reckless behavior. Prevalence onset, typically age of 25, affects 1 to 100 people in their lifetime. 36% of these individuals attempt suicide. Comorbidity is anxiety disorders and substance abuse disorders. So biological basis of mood disorders, major depressive disorder, which, like I said earlier, is more of an acute depressive disorder that lasts shorter amounts of time. It's more transient, but it's more severe. You're gonna have thoughts about ending your life, thoughts of worthlessness, thoughts of you not having any merit in society. Bipolar disorder is gonna be relatives that have 9 times the risk. Oh, I didn't even read the percentage rates. Sorry, guys. Relatives have doubled at the risk of developing the disorder. Identical twins have a 50% concordance rate, and fraternal twins have a 38% concordance rate. But bipolar disorder relatives have over 9 times the risk. Identical twins have 67% concordance rate, and fraternal twins have 16% concordance rate. Hormones, elevated cortisol, which is a stress hormone. We covered that in the last chapter. Causes consequences of depression, a risk factor for future depression. Cortisol activates the amygdala and deactivates the prefrontal cortex, which is disturbances in connections in depression. And yeah, obviously we know if that disrupts the frontal cortex, that is going to decrease a lot of that motor ability, which is going to actually be involved in the psychomotor agitation and the psychomotor. Oh my God, did I forget already? I'm so sorry, guys. but it's involved in the psychomotor agitation. I'm sorry, guys. I'm learning it just as you guys are learning. So I'm so sorry. I have to go back. I just want to make sure I hit these right. You know what? It's okay. It's okay. Let's just go back. Okay. I'll cover them and I'll cover them. I'll cover them. I'll cover them. So yeah, I'm pretty sure psychomotor retardation. Sorry, guys. So the reduction of moving a lot of those motor details. So if you're getting this increased depression, obviously it's going to affect the motor parts of your frontal cortex, and it's going to affect a lot of the judgment, and it's going to affect your empathetic nature. So you're more likely to be apathetic, and you're not going to really care about a lot of what other people do and other people think. You're going to be moping, like I said, because you have those psychomotor abilities or aspects, and you're pretty not going to be accessing a lot of judgment and not having as much care with a lot of the things that you do. So neurotransmitters. So, oh God, this is beautiful. Just look at this neurotransmitter. So mood disorders often involve imbalances in neurotransmitters, particularly serotonin and norepinephrine. The neurotransmitters are involved in bodily functions that disrupt mood disorders. Many medications designed to treat mood disorders working by altering neurotransmitters activities in neutral synapse. Medications for depression usually increase serotonin and norepinephrine activity. Medication for bipolar disorder is lithium, which blocks norepinephrine activity in the synapses, which obviously is going to decrease stress. Yeah, and we're gonna also talk about SSRIs with these two SSRIs, which are one of the most popular medications for depression. So depression, the amygdala is an important assessing emotional significance of stimuli. Experiencing emotions, and depressed individuals react negatively to an emotional stimulus, such as a sad face, with a greater amygdala activation than non-depressed individuals, more prone to react emotionally to a negative stimuli. So what this is saying is depressive individuals. Sorry, I had to take a drink. My mouth is getting dry. But these depressed people have this. They have, when they look at something, they're gonna have this vicarious emotion. They're gonna see it, and then they're gonna pretty much project a more negative emotion in their mind. So than a person with no depression. So if they see a sad face, if they see something that's gloomy, or if they see something that is associated with a negative emotion, they're pretty much just going to relay some sort of negative emotion subsequently. Prefrontal cortex is important in regulating and controlling emotions. Its decreased activation in depressed individuals may inhibit the ability to override negative emotions and greater difficulty controlling emotional reactions. Stressful life events often precede on the onset of depressive episodes. However, not everyone who experiences stressful life events develops depression, suggesting predispositions or vulnerability factors could be involved. Genetic vulnerability, alteration in the 5-HTT-LPR gene regulates serotonin, one or two short alleles, plus stress from a life event increasing the likelihood of the experience of excessive or of a depressive episode. Excuse me. A study of a gene-environment interaction in people experiencing chronic and short versions of depression and the gene combination with childhood maltreatment. So yeah, what this is saying is a lot of this is based on a lot of socio-environmental, and if you have these short alleles within this serotonin regulating gene, and you have negative social environmental factors, it can lead to depression, or you're more likely to get depression. So cognitive theories suggest that depression is triggered by negative thoughts and interpretations, self-evaluations of experiences. The diathesis model assesses cognitive vulnerability plus stressful life events, and that equates to depression. Aaron Back theorized that depression is prone to people who possess mental dispositions to think about most things in a negative way, which are depressive schemas. Depressive schemas contain themes of loss, failure, rejection, worthlessness, and inadequacy. It may develop in childhood responses to adverse experiences, dormant until activation of stress, negative life events, and prompt dysfunction and pessimistic thoughts about self-worlds and future, maintained by cognitive biases which lead us to focus on negative aspects about experiences, interpret things negatively, and block positive memories. So basically what this is saying is this depressive schema makes a lot of those stereotypical neurotic emotions within the within the brain. So it's going to cause us to have continuity for a lot of these depressive and a lot of these neurotic emotions. And it's going to keep us in that depressed state because obviously, if we keep thinking about a lot of those depressive and a lot of those neurotic negative emotions, it's going to cause us to have this cyclic nature where we're in this constant infinite loop of sadness. So specific negative thinking style, a sense of hopelessness equates to depression. We covered that in the last chapter where the dog learned helplessness. Negative thinking refers to tendency to perceive negative life events as having stable. It's never going to change the global. So stable is it's never going to change, meaning that it's a stable pattern, and global meaning that this is across my whole entire lifespan. This is global, like global meaning one singular Earth. This is gonna be global, my one singular life. It's all around it, just like the world's all around you. So hopelessness is an expectation that unpleasant outcomes will occur, or desired outcomes will not occur. And there's nothing one can prevent, such as outcomes seen as primarily causing depression. So we know that hopelessness is the feeling that the same outcome is going to constantly occur, and you have no locus of control over it. You can't do anything but accept. So it causes us to quit. It causes us to lose that self-efficacy, which is that motivation that. And we obviously need the motivation to bargain some sort of endeavor and bargain that motive just to get out of that situation. Rumination, depressed mood. Rumination increases the risk of mood. So rumination is repetitive, passive focuses on the fact that one is depressed and dwelling on depressed symptoms rather than distracting oneself from symptoms or attempting to distress them with active problem-solving manners. So rumination is just thinking, active thoughts, having that cyclic nature about that negative emotion that's constantly persisting, and not abstaining from distraction and abstaining from a lot of these problematic aspects or problematic events or actions that you could take to sort of reduce your anxiety. So statistics, 90% of the people who complete suicide have a diagnosis and at least one mental disorder, most frequently mood disorders. 10th leading cause of death in the ages, and for all ages 2010, an average of 105 each day, four times higher among males. 79% of all suicides than females. Most males most commonly use firearms. Females most commonly use poison. So substances abuse problems 10 times greater in individuals with alcohol dependence. Previous suicide attempts, access to lethal means in which to exact firearms in the house, precursors, withdrawal from social relationships, feeling like a burden, engaging in reckless risk, taking behaviors, sense of entrapment, unable to escape feelings or external circumstances, cyberbullying, suicide of a family member, and serotonin dysfunction. Schizophrenia symptoms, hallucinations, a perceptual experience that occurs in the absence of external stimulations. Auditory hallucinations are most common. Delusions, the belief that are contrary to reality. Paranoid delusions, which can be paranoid schizophrenia, is a belief that people and agencies are plotting to harm against you. Grandiose delusions, which can be like thinking that you're God, thinking that you're the one above all, thinking that you were sent here by some specific person to do something that is extraordinary or superstitious, not even real. Somatic delusions, the belief that something abnormal is happening to your body. Disorganized thinking, which is disjointed and incoherent thought process, which disorganized schizophrenia is pretty much having these rough, disorganized thoughts and not knowing what to align by and really do. So it could cause you to poop or defecate in public, and it can cause you to urinate in public and just do a lot of these things that a normal, coherent human wouldn't do. So catonic behavior is decreased activity to the environment, or catatonic behavior. Negative symptoms decreases and abstinence of in certain behaviors, emotions, drives, avolition, which is pretty much reduced will to do something, alogia, which is reduced speech output, asociality, which is just reduction in socialization, and anhedonia, which is abstination from a lot of hedonistic things, which is just pretty much pleasure. Schizophrenia prevalences affects 1% of the population. Genetics risk is 6 times greater if parents have schizophrenia, even if adopted. Dopamine hypothesis: an overabundance of dopamine or too many dopamine receptors are responsible in the onset of maintenance of schizophrenia. Drugs that increase the dopamine levels can produce schizophrenia-like symptoms. Medications that block dopamine levels can reduce symptoms. High levels of dopamine in the limbic system can coordinate to hallucinations and delusions. Lower levels of low dopamine in the prefrontal cortex can lead to negative symptoms. Brain anatomy: enlarged ventricles, reduced gray matter in the frontal lobe. Many show less frontal lobe activity when performing cognitive tasks. Which enlarged ventricles obviously can lead to, that means there's some sort of brain atrophy that's occurring, which is obviously reduction of a lot of the gray matter within those ventricles, or a lot of the neurons within those ventricles. And there's a lot of neurons that are in the ventricles. So if it's leading to some sort of brain atrophy, that's not going to be good. And it could lead to fragmented thoughts. Events during pregnancy: obstetric complications during birth. I don't even know what that is. Mother's exposure to influenza during the first trimester, and mother's emotional stress, which mother's emotional stress can be concorded to her susceptibility to influenza. But before I do anything, I'm going to search up this word. So, obstetrics is the medical specialty concerned with the care of women during pregnancy. Okay, my bad. So that's what it is. So, obstetrics, if I'm saying that right, is concerned with the mother's health during pregnancy. Dissociative disorders is characterized by an individual becoming split off or dissociated from their core sense of self. Memory identity becomes disturbed. Dissociative amnesia, unable to recall an important personal information, usually follows stress or from a traumatic experience. Dissociative fugue, individual suddenly wanders away from home, experiencing confusion about their identity, and in some cases may adopt a new identity. Depersonalization/derealization. So depersonalization is the feelings of being dissociated with yourself. You're not in your body, you're not yourself, and you pretty much are unfamiliar with your families and your kinships. Derealization is some sort of unreality or detachment and unfamiliarity with a lot of the inanimate objects and a lot of the things around you. So dissociative identity disorder, formerly multi-personality disorder, which identifies and exhibits 2 or more separate personality identities and involves memory gaps from time from one identity and from which one identity is charged. Individuals tend to report a history of childhood trauma and adopt multiple personalities. So these people end up taking trauma and they use another persona as a defense mechanism to help alleviate a lot of that stress and help dissociate them with the stress by entering a new personality inside of their brain. So let's go on to the next the next slide. Personality disorders, prevalence. Slightly over 9% of the U.S. population suffers from personality disorder. Avoidant, schizoid personality disorders are most frequently antisocial and border personality disorder. Cluster A, paranoid personality disorder. Schizoid personality disorder. Schizotypal personality disorder. Cluster B, antisocial personality disorder. Histrionic personality disorder. Narcissistic personality disorder. Borderline personality disorder. Cluster C, avoidant personality disorder. Dependent personality disorder. And obsessive compulsive personality disorder. So paranoid personality disorder. So paranoid personality disorder is pretty much just having having this sort of disorder that's characterized by a lot of paranoia and a lot of mistrust towards other people. So you're pretty much not going to be socializing a lot with a lot of other people because you feel that maybe there's some sort of malicious or just some sort of malignant intent when it comes to anybody around you. So you're going to avoid people at all costs. Schizoid personality disorder is a mental condition characterized by lifelong patterns and emotional attachment and social isolation and lacking of interest in close relationships. And yes, I did search that up, guys. So yeah, it's pretty much schizoid personality disorder is pretty much just an attachment from a lot of people and just not having that emotional and sexual excitation. Schizotypal disorder is actually don't know that one, so I'll switch that one as well. Schizotypal personality disorder is a disorder also known as schizotypal and mental disorder characterized by the thoughts of disorder paranoia and social anxiety and derealization, psychosis, and unconventional beliefs. So this disorder is it has a cluster, a lot of clusters of things. So schizotypal personality disorder has a lot of these. It's another feeling of being dissociated with life, not there, derealization, um, a lot of these paranoid symptoms as well, and yeah, just I honestly I really can't explain it. A lot of the schizophrenic aspects, I'd say, antisocial personality disorder is a disorder where you're pretty much a sociopath is how I like to view antisocial disorder. So you're not doing a lot of moral things. You're gonna abstain from a lot of rules and principles. You're gonna do what you want. You feel like you have your own liberty, and you pretty much don't care what people do or say, and you don't care about morals or morality. Um, Histrionic personality disorder can be characterized by a lot of excessive, a lot of excessive traits like mania, for example. Um, so you're gonna be doing a lot of excessive things and a lot of attention-seeking things as well. Narcissistic personality disorder. We know what narcissistic personality disorder is. Pretty much someone who's self-involved. They think they're the best. They have crazy, abundant grandiosity. So they're just thinking they're the best person in the world, pretty much, and they're just so vain. Borderline personality disorder is actually it's kind of like bipolar disorder, but borderline personality disorder is more dependent on people. You have more dependence on another person, and you're more of a clingy person. So avoidant personality disorder is pretty much avoiding people, trying to circumvent people at all costs. You don't want to be involved with anybody. Dependent personality disorder is having dependence on someone, acting like a child, thinking that, oh, I need someone to give me command so I have something to do in my life. Like you need someone, and also if you could so it's just yell or do something wrong, they could start crying and acting like a child, and a lot of regressive behavior. Obsession compulsion disorder, which is OCD. Um, we know OCD. We just discussed it. A lot of obsessions and a lot of compulsions characterized by classical conditioning and things of that sort. So borderline personality disorder, symptoms cannot tolerate thoughts of being alone, will make frantic efforts to avoid abandonment, relationships are intense and unstable view of the self by suddenly display shifts of personal attitudes and interests. Oh, they're highly engaged in reckless self-destructive behavior and show intense inappropriate anger and can be moody, sarcastic, bitter, and verbally abusive. So a lot of these people with BPD or borderline personality disorder can have a lot of these flamboyant characteristics and can pretty much it's kind of like BPD, which they can be pretty erratic and revert to one thing to the next. Can be pretty strange and just pretty spontaneous. So, prevalence afflicts about 1.4% of the U.S. population. Comorbidity, anxiety, mood, and substance use disorder causes core personality traits, impulsivity, emotional instability, and they show a high degree of heritability traits. Many individuals report childhood abuse. So these antisocial factors characterize complete lack of regard for people's rights or feelings, repeatedly performing illegal actions, lying or connecting or cunning or coning others, impulsivity and recklessness, irritability and aggressiveness, failure to act in responsible ways, lack of remorse, over an inflated sense of self, superficial charm, lack of ability to empathize. So these people are pretty grandiose. These people have some narcissistic traits. They don't care. They're impulsive. They're reckless. They're gonna do a lot of destructive things. They have no morality, pretty much, and they have no empathy for anybody. So if you really want to think of someone with antisocial disorder, definitely think of somebody like Patrick Bateman. Patrick Bateman was a pretty antisocial person. If you ever watch American Psycho, you know that they depict a psychopath perfectly because a psychopath has antisocial aspects. There's a comorbidity. Antisocial personality disorder is literally basically psychopathy. And sociopathy is also connected closely with psychopathy if you didn't know. But psychopathy is pretty much just a predisposition in the brain structure, while sociopathy is a honed sort of psychopathy. So it's honed over the environment and the factors and stress experienced throughout the environment you're put in. So sociopathy is more of something that's honed, while psychopathy is more of something that's just a predisposition. Genetics, personality, and temperament dementias related to the disorder: fearlessness, impulsivity, antisociality, and callousness. They all have genetic influence. Adoption studies suggest that antisocial behavior is determined by the interactions of genetic factors and adverse environmental circumstances. Individuals with antisocial personality disorder fail to show fear in a response of environmental cues, signal punishment, pain, or noxious stimulation. They show less skin conductance, which may indicate emotional deficits. Their brain anatomy research has revealed less activation of brain regions involved in an experience of empathy and feelings concern of others, greater activation of brain areas involved in self-awareness, cognitive function, and interpersonal experience. ADHD, neurodevelopment disorder, involved in developing problems of personal, social, and academic and social and intellectual functions. ADHD is a constant pattern of inattention and or hyperactive impulsive behavior. It interferes with normal functions, and the symptoms can be difficulty sustaining attention, failure to follow instructions, disorganizations, lack of attention to detail, easily distracted and forgetful, hyperactivity, excess movement, interrupting and intruding on others, blurting out responses before questions have been complete, and difficulty waiting. Boys are 3 times more likely to have ADHD than girls. Low education, attainment, low social status, unemployment, wages, substance abuse problems, and relational problems. Yeah, but a lot of people with ADHD also don't have a sufficient amount of dopamine in the right area, which we'll cover more in next chapters. But ADHD, or in not next chapters, but next slides. Inattention, 71% heritability. Hyperactivity, 73% heritability. Dopamine genes involved are thought include at least 2 or more important regulations of dopamine. Individuals with ADHD show less dopamine activity in key brain regions, those associated with motivation and reward. So that's going to be more in the frontal cortex. A lot of the frontal cortex contains for motivation and reward, if I can remember, should be the ventral medial cortex, along with motivation and reward, and the ventral tegmental area is obviously related to a lot of that motivation that you get, a lot of that dopaminergic boost. The brain anatomy studies shows smaller frontal lobe volume, and it shows less activity when performing mental tasks. The frontal lobe inhibits behavior and may explain hyperactivity controlled in behaviors in ADHD. So if there's not a lot of dopamine flowing to the frontal lobe, it can't inhibit that behavior, because obviously we know the frontal lobe is primarily involved in regulating, judging, and assessing a lot of these situations, and creating that sort of emotional regulation so you don't act out of character. Obviously, us children and adults have a lot of irregulability, creating and developing a lot of these emotions because their frontal lobes aren't developed. Children don't have developed frontal lobes, which means that they don't have a lot of emotional regulation on themselves. So this obviously is going to lead to a lot of impulsivity with children. So that's a lot of the reasoning why a lot of children can be impulsive and relay their emotions so quickly. Dopamine. So yeah. Let's just move on to the next slide. So symptoms, deficits in social interactions. This is the autism spectrum disorder. Yeah, okay. So deficits in communication, one-word responses, difficulty maintaining a conversation, echoed speech, and problems understanding nonverbal cues. Repetitive patterns of behavior interests affects approximately 1.1 in 88 children in the U.S., 5 times more common in boys, identical twins, 60 to 90% concordance rate, fraternal twins, 5 to 10% concordance rate. Genes involved are those important in the formation of synaptic circuits to facilitate communication in different areas of the brain. So factors can contribute to new mutations, pollutants. That's a factor. Last but not least, childhood vaccinations and autism disorder. There is no correlation with in science proving, or some scientific study proving, that vaccinations can lead to autism spectrum disorder. So please don't believe that. But yeah, this has been a really long video, guys, but disorders is something that is not concise at all. There's a lot of disorders. We covered a lot of disorders in this video. A lot. At least like 20. Especially in that one slide. But yeah, I'm going to call it a day. It's been almost an hour and 17 minutes. If you guys are still listening, thank you so much. But that is going to be it. Goodbye. Enjoy.